Alright, so that's kind of the main of esophagus problems. So let's jump to stomach problems. What can we have here? It's kind of a problem with that LES sphincter again.
The GERDs.
Good. GERD.
Gastritis.
Good. Gastritis.
A sliding or rolling hernia.
Hiatal hernias. Gastroenteritis. You're gonna have something called dumping syndrome. And that's kind of a problem with the entire intestines. Just kind of lets everything run through. Alright, so let's start with GERD. What are some signs and symptoms you'll see with GERD?
Heartburn.
Good.
Yeah.
Cramping, yeah.
Do I get like chest pains, or is that the same thing as heartburn?
You can have chest pains also. Will their pain worsen when they lay down or when they stand up?
They lay down.
Good. How come?
Because of the gravity, it just makes it easier to come up.
Perfect. So we've got this constant irritation of this acid kind of just coming back up to the throat and irritating the lining of the esophagus. So what are some complications?
It'll change the cells.
Good. Into what is that called?
Columnar cells. It's called Barrett's esophagus.
Good. So the normal lining of the esophagus is squamous epithelium. If we've got that constant irritation, it can change that squamous epithelium into columnar epithelium, which is precancerous. So we call that stage Barrett's esophagus. And we want to monitor for it really carefully to make sure that it doesn't turn into esophageal tumor, because those can metastasize really quickly, and they're kind of toast as soon as it starts metastasizing.
So is there a difference between GERD and acid reflux?
Yeah, pretty much the same thing. I think it's the same thing. I think they just kind of use them interchangeably.
Well, I have acid reflux, so that's nice to know I'm going to get cancer one day.
No, doesn't necessarily mean that you will get cancer. It's only like, the percentage is like 1% of people who get Barrett's esophagus, but it's just monitoring for it.
But at least you're learning how to control it.
That's true. Let me think, where was I going? Oh yeah, how are we going to diagnose GERD?
Isn't it you have to have it at least 2 times a week for so long before they'll...
Yeah, I think something like that. What about like procedures that we can do to actually look at the stomach?
An endoscopy?
Good. An endoscopy? That's one of them. We can also do a GI, what is it called? Let me look. Oh, a gastric analysis. It might be that their stomach is making too acidic of acid, and so like it's kind of eroding everything away and causing this acid reflux. We might do like another scan or some other thing to find out if they have a hernia, because hernias are also can also cause GERD. They're a risk factor for GERD.
A hernia anywhere.
Like a hiatal hernia.
Okay.
Sorry.
So
You're gonna have like
So
a,
I'm just checking. I'm just.
if you have a hernia down here.
One of the lower ones, peritoneal hernia.
Yeah, sure.
From GERD.
Okay. What are we gonna do for this patient? We've found out that they do have GERD and we want to avoid Barrett's esophagus. What are we going to do?
I would sit up for like an hour or 2 after eating.
Good.
Have their
Comes.
bed elevator, tell them how to eat right before they go to bed.
Good.
Like within what, 3 hours, 2 hours?
I think it's at least 2 hours.
Like you avoid fatty foods and like carbonated stuff.
Spicy.
Good.
Especially.
What about, so we've got the nursing things that we can do. What about medical intervention we might expect the doctor to order?
Antacid.
Space 2 blockers. I have no space.
Good. know those 3 medications, so the antacids, the PPIs, and the H2 blockers, know which medications go under each of these sections, because he's going to test you on that. So he might say, your patient has been ordered cimetidine, which is a blank, and he'll test you on that, something like that. All right.
And that's number 40 on the slide, right?
That's, yeah, on slide 40. Good, good.
I know. But still, I couldn't even.
So if these antacids, H2 blockers, and PPIs aren't working, what procedure can we do? Do you guys remember what it's called?
Yeah.
It's
You fold the stomach around and
LNF.
straighten it, right?
Yeah.
Oh, yes.
It's called a laparoscopic Nissen fundoplication. So they take the fundus of the stomach, which is that top part, and they fold it around itself, so it'll look kind of like this on each side, and then they stitch it together. This just kind of helps reinforce that pyloric sphincter so that the acid doesn't get back up into the esophagus. Because if the pyloric sphincter is working a little bit, if we reinforce it, then it will be closing all of the way.
What is the difference? Because it says a small percentage of patients can't have this type of surgery, and they require an open fundoplication. Like, what would be the difference in that?
It would just be they would open them completely up instead of doing it laparoscopically. So like laparoscopically, they do like 3 or 4 incisions, small incisions, and they put in cameras. And then non-laparoscopically, they will just cut them completely open, and so they can see everything. They don't use cameras, they just look. So I'm not really sure why some people aren't candidates for laparoscopic though, because that's a lot less invasive. So I want to understand, like, maybe they have some other cancer problem, or I'm not totally sure.
Okay.
All right, so kind of talk about Barrett's esophagus. Let's jump to hernias. So we've got those 2 different types of hernias. We've got the sliding hernia and the rolling hernia. So that's kind of the sliding hernias. The top part of the stomach just slips through the diaphragm. And then the rolling hernia, the fundus of the stomach kind of comes up above the diaphragm, like that. So the difference in between these 2 is the signs and symptoms that you'll see. One's going to be a lot more severe, and one's going to be a lot, like, not as severe. So sliding hernias are just kind of small, they're not as severe. We're going to see things like heartburn. They're going to have maybe a little bit of mild chest pain, but nothing too much. They might belch a little bit or have some signs and symptoms of GERD, kind of on both of them. With the rolling hernia, you're going to have a lot more severe signs and symptoms. You're going to have chest pain that's a lot more similar to angina. Kind of like breathlessness, especially after eating, because you've got this huge piece of your stomach pushing on your diaphragm, and if there's any food in there, then it's going to make it even worse. And then laying down is going to make it worse too, because it's just easier for that to slide up through the diaphragm. So what are we going to teach our patient if they have a hernia? And lots of times with these kind of hernias, we don't really do much medical management. We kind of just let it slide in and out. But what do we do to teach them to avoid it sliding up into the diaphragm? Do you remember anything?
Well, I'd imagine, like, careful on the activity and not to eat too much.
Good. So you want to teach them not to do too much vigorous activity. Teach them not to wear too tight of clothing. Lots of patients who have like other hernias will have an abdominal girdle. And so with those patients, usually we'll do the Nissen Fundoplication to fix the hernia if they have to have that tight girdle on.
These are different than like other hernias, right?
Yes.
Okay.
There's a bunch of different types
These
of
are
hernias.
just like stomach ones.
Other hernias are when the
Like
intestines pop
stringy
through
really
the
bad,
muscle.
yeah.
Yeah, so be careful, like, not to wear tight clothing, like you said, but also like coughing or sneezing or,
Not straining when they're
to poop.
having a bowel movement. Good.
You feel it pop.
Yeah, these patients can feel it come in and out though. Like,
Oh, gross.
yeah, I had a friend who had a patient with one of these, and then she was like, "Oh, it popped out," and then she's like, "Give me a second," and like pushed it back in herself. So kind of weird.
Okay, so I think that the more it goes above and below where it's supposed to, like the worse it would be, the more chances of it happening again. Because it gets weaker around the muscles.
Yep.